Hello, my name is Mohammed Umar Akram. I'm a hospitalist at Advent Health Orlando, and today I'm going to present a very interesting case of life-threatening ventriculitis due to Rothia mucilaginosa in a patient with relapsed AML. Diagnostic and management challenges. CNS infections such as meningitis, cerebritis, and ventriculitis are rare but fatal complications of Rothia mucilaginosa infection. We are going to discuss a unique case of ventriculitis in a patient with relapsed AML. We will be highlighting the diagnostic challenges and treatment complexity encountered in managing the patient. A 48 years old man with relapsed AML developed confusion, drowsiness, and speech impairment during his hospital stay a few weeks after receiving reinduction chemotherapy. On examination, he was tachycardic, hypotensive, and febrile, with a temperature of 102.7. Cardiopulmonary exam was unremarkable. Neurological examination revealed confusion, neck stiffness, and psychomotor slowing without focal deficits. In addition to initial resuscitation, a comprehensive infectious workup was undertaken, including lumbar puncture. CSF analysis demonstrated neutrophilic pleocytosis and low glucose levels, concerning for bacterial meningitis. However, CSF cultures and microbiological workup, including next-generation sequencing, were all negative. The patient was maintained on empirical meningitis coverage with vancomycin and meropenem. CT head and brain MRI showed hydrocephalus along with ependymal enhancement, concerning for ventriculitis. The rest of the workup remained non-diagnostic. Although he did not deteriorate further clinically, there was no improvement. With persistent symptoms and worsening encephalopathy, the infectious diseases workup was repeated again. This time, blood culture, CSF culture, and NGS revealed Rothia mucilaginosa, which demonstrated susceptibilities to penicillin and vancomycin. Targeted therapy with high-dose continuous infusion penicillin G was initiated for 6 weeks. Intrathecal vancomycin was also administered to potentiate antimicrobial activity. Hydrocephalus was managed with an LP drain, followed by a placement of external ventricular drain and ultimately a ventriculoperitoneal shunt. This multidisciplinary treatment resulted in neurological improvement and clinical stability. The patient remained hospitalized for continuation of care. Rothia mucilaginosa, a gram-positive coccus and inhabitant of human oral cavity, is a rare opportunistic pathogen that can cause life-threatening infection in immunocompromised hosts. It is known for its strong adherence primarily through biofilm production. Most reported infections include bacteremia, endocarditis, cellulitis, and bone and joint infections. Meningitis and ventriculitis are extremely rare, with only a few reports available in literature. This case is unusual, not only because Rothia ventriculitis is an extremely rare manifestation, but also because the initial workup was unrevealing, highlighting the need for persistent clinical vigilance and multidisciplinary management. Repeating investigations, including lumbar puncture, cultures, and next-generation sequencing, should be considered when patients fail to improve. Our patient was managed with systemic as well as intrathecal antibiotic therapy, and the decision to utilize both therapy can be made after discussion with infectious diseases specialists. Management of complications such as hydrocephalus is critical for neurological and clinical recovery. Thank you so much for your time.